Alright guys, let's get busy talking about our cervical pathology, and we're going to largely be talking about our cervical dysplasia spectrum. And so let's first talk about the cellular architecture of our cervix in order to orient ourselves to what is happening here in this spectrum of dysplasia. So if we were to zoom in here to our cervix, we're going to see that the cervix is characterized by these squamous epithelial cells here on the outside that I'm drawing in orange, and then as we move in closer to the uterus, this starts to turn into a columnar glandular epithelium, which I am denoting with these square block-like cells in light blue. Now, this area has a special name, and it is called the transformation zone, which I'm kind of denoting with this pink star. And it's incredibly special because it is very susceptible to malignant change. And this is because this is a change between squamous and columnar, and so this can lead to the production of cancers in this area. And so our cervical area is very susceptible to cancer, and namely it's going to be largely caused by HPV infection. Now, HPV stands for human papillomavirus. This is a virus that is ubiquitous, and most young people are exposed to it through sexual encounters. And so HPV infection are going to lead to disordered epithelial growth at the transformation zone. And remember, we denoted our transformation zone with this little pink star. It's going to be a really high yield phrase when it comes to cervical pathology. And this transformation zone can continue to progress to more and more progressive malignancy. And so there's some special words and nomenclature that they use with respect to this transformation zone. So in terms of this disordered growth, it can move through 3 stages: CIN1, CIN2, and CIN3. And this can end with invasive squamous cell carcinoma. So let's go ahead and take a look here at this diagram. And so you'll see we have normal tissue here, and you'll note that we have our squamous type cells, which I'm kind of denoting in orange here. And then these squamous cells are going to continue over here. And then in light blue, we have our columnar cells over here. And so this is the transformation zone all up in this area with my big pink star. I'm going to clear this pink star so we can get a little more granular. In CIN1, we start to see some abnormal cells start to form, and this is going to progress through CIN2, CIN3, and in CIN3 and invasive carcinoma, we're going to start to see a lot of like abnormal mitotic activity. So you would expect to see a lot of pink and purple mitotic activity here. And then when it comes to invasive carcinoma stage, this is characterized by breakage through the basement membrane. In terms of being able to differentiate CIN1, 2, 3 from invasive carcinoma based on the cellular characteristics, that is not a task you're expected to be able to do on the step 1 exam. However, I would note it's important to be able to note that breakage through the basement membrane is going to be characteristic of invasive carcinoma. That's going to be something that you would be expected to do on exam day. So when it comes to our etiology, we talked about the fact that it's HPV exposure that is going to be the most common cause of our cervical cancers. However, there are some other minor risk factors that we can talk about, such as multiple partners, because we know that HPV is spread through sex, and then smoking, because we know that smoking leads to carcinogenic change throughout the body, but this is particularly high yield in cervical cancer. And then DES exposure, I usually characterize as being associated with clear cell adenocarcinoma in the top 2/3 of the vagina. However, there's a loose association with cervical cancer as well, but I would like you guys to be thinking primarily about DES as exposure for vaginal cancer, especially the top 2/3 of the vagina. And then immunocompromised states also are going to lead to cervical cancer. And this is because the immune system can keep our HPV infection at bay and kind of keep it a little bit silent and soft. Whereas if we are in an immunocompromised state like HIV/AIDS or on immunocompromising medications, our HPV can work a lot faster and change that transformation zone a lot faster, leading to cervical cancer much more quickly. And so when we think of our presentation of cervical cancer, there's not a lot that pops out to me in terms of presentation. Perhaps the one complaint we can see is vaginal bleeding after intercourse, because the cervix can become friable, and then if this is irritated during intercourse, it can bleed a little bit. But in reality, most cervical cancer is going to be asymptomatic for a long time, and it's going to be identified on routine screening. So we start to see abnormal cells on our routine pap smear screens. And what is a pap smear, you might ask? And so a pap smear, which I'm going to highlight with this orange little stylet or Q-tip, is a little probe that we put into the cervical transformation zone. So we go ahead and insert this probe up into the vagina, and then we put it right here in the cervix, and we brush it a little bit, and we get some cells there because we know that this is the area that is most likely to have cancer. And we look at these cells under the microscope, and we're looking to see if there is any abnormal growth here in the cervical transformation zone. And so what we expect to see if we do see transformation is something called koilocytes. So in our histology, we see koilocytes, which are pathognomonic for HPV infected cells. And for those of you who don't know, pathognomonic essentially means that this cellular finding is unique to HPV infection. So it's a great way to get easy points on exam day. These are described as a racinoid nucleus with a perinuclear halo. Let's go ahead and take a closer look here. I love this histology. I'm obsessed with it because I think they look like koi in a koi pond, like decorative koi. So I always imagine these as like a fish with these big bulging eyes from the perinuclear halo and the racinoid nucleus. And the fact that they are called koilocytes helps me remind that they also look like koi, and they just look so distinct on exam day, and this really helps me get questions right related to HPV. However, I want to mention one thing, and that there is a common similar looking cell type in a vaginal or cervical complaint, and that's going to be clue cells. So let's take a look at clue cells here, and these are going to be secondary to Gardnerella infection, and you'll see they look really similar in the fact that they kind of have this like bluish gray stain, and they have what can kind of look like a racinoid nucleus. However, it's going to be all about history here and differentiating. So in a Gardnerella infection, you're going to expect like a gray or fishy-like exudate coming from a vaginal orifice, and that's going to be usually in the setting of multiple recent partners, and you're going to see these clue cells, to me, which seem a little more like granular, like they see like they have like kind of gray and like tissue paper. They're often described like crumpled paper, whereas our koilocytes don't really have that crumpled paper appearance quite as much. You can see that they look similar, so I don't want you guys to be looking for a pathognomonic cell and being like, oh my god, that's definitely a koilocyte, when it's actually a clue cell. So be sure you be able to differentiate these two based on appearance and also history, looking for that gray fishy odor in the setting of our clue cells from Gardnerella infection, whereas HPV exposure, pap smear in our patients with cervical cancer. So now that we talked a little bit about the histology, let's talk about our microbiology. So in terms of our microbiology, this is, like we said, associated with HPV, and the strains they really like you to know on exam day are 16, 18, 31, and 33. That is really high yield to know. I would say especially high yield is going to be strain 16 and strain 18. So they like you to know more granular detail about 16 and 18. Specifically for 16, they want you to know that this expresses the E6 gene protein, and this is going to lead to inactivation of P53. And we know that P53 is a protein that's responsible for inducing apoptosis in abnormal cells. And so if this is not happening, these abnormal cells are going to have a party and just grow out of control. And then in our HPV strain 18, this is going to express the E7 gene protein, and this is going to lead to inactivation of RB, which we know has a similar function in the term that is a tumor suppressor gene. And if it is not present, then we're going to have uncontrolled growth of abnormal cells. So let's imagine these cells are just growing and growing and growing, and nothing is keeping them in check. What's going to happen eventually when we get down to our invasive carcinoma? The classic presenting feature of invasive carcinoma is going to be urinary complaints. So the invasive carcinoma can obstruct our ureters, and this is going to present with hematuria and hydronephrosis and renal failure. So you may see bumps in creatinine on lab values, or perhaps red blood cells in a urinalysis, or difficulty with emptying the bladder. These are all going to be presenting complaints of an invasive carcinoma, and these are patients who perhaps didn't get screening with pap smears, and so they're presenting with end-stage disease, and this is how it will classically present. So we talked about our management in terms of routine pap smears, and this is to catch this disease process before it becomes invasive. And then test writers also like to ask about relative frequency, and so I want you guys to know that endometrial is more common than ovarian, which is more common than cervical, and so that's going to be another important high yield thing on test day. I also want to point out that since this is a squamous cell carcinoma, we can expect keratin pearls, but squamous cell carcinomas can happen independent of HPV infection, and they can also happen outside of the cervix. So it's important to know that just because you see keratin pearls does not mean this is a cervical cancer. However, you can rely on things like koilocytes to be like, that is a more specific finding for cervical cancer. This squamous keratin pearl type pathology can apply to many cancers across the body, and so I just wanted to differentiate those histologies for you guys. Lastly, let's go ahead and talk talk about cervicitis, which we will cover a lot more in depth in our infectious disease processes, but essentially this is infection of the cervix, and this is going to present with things like pelvic pain, cervical or vaginal discharge, especially something that's purulent, or in the case of Gardnerella infection, gray and fishy, presenting with our clue cells, which we talked about earlier. And then this is usually going to have an erythematous and friable cervix, which can also happen in cervical cancer, but this is going to be more of acute onset, whereas our cervical cancer is going to be more chronic. And our management here is going to be antimicrobials, depending on what organism is identified and deciding on whether or not empiric treatment is necessary. These are details that will be covered more in our infectious disease unit. So in terms of our high yield review, it's important to know that cervical pathology is happening at our transformation zone, and the big heavy hitter in terms of a risk factor is going to be HPV exposure. We talked about our progression through the transformation zone from CIN1 to invasive disease that penetrates through the basement membrane, and then we talked about our microbiology and our histology findings that are high yield in terms of the types of HPV and the types of pathognomonic cells like koilocytes. And then we talked about how invasive disease is going to present with urinary complaints or urinary aberrations on lab values. And then we wrapped up by talking about cervicitis and how this is going to be an acute cervical problem related to sexual exposure to different microbials. I hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye!